SABCS and Tonio Breast Cancer Consortium and Early Breast Cancer. I think first question I have before the talk, again, question to all members. Why are these drugs so much of clinical stage?
So we don't name the drugs. I think that's the simplest answer. If we named it, I'm sure we would have been simpler. But and these are just the generic names. Actually, if you go by the trade names, which in the US they are very well known, I think I can't even pronounce them. So if I can just have the slides focused. So slide change. What? 2 minutes. Okay, 2 minutes. We'll wait. We have. Okay. So what I will be doing, Dr. Ayasha, is not just talking of the SABS. I think that's one aspect. Mostly we'll be covering the role of Abemaciclib in EBC. So what I will talk of is more of why at all we need this, because EBC is generally considered a very good prognosis. Do we really need more drugs there? So I lay out the data for why we need some more treatment there. And within some 10 minutes or so, I'll hand over to Dr. Sendil for explaining the role of Abemaciclib in that setting, because that really is where our attention is now. The adjuvant treatment of EBC, where it works, where we need the CDK4 inhibitors, and what those drugs are being given. So these are my disclosures, and I hope you start my time now. Thank you. So these are the disclaimers, and what we have today for Abemaciclib is indications approval in two settings, the EBC and the MBC. And like I said, I am talking about the disease burden and unmet need in HR positive, HER2 negative EBC. Now, EBC is something we know is typically a good prognosis. Overall, breast cancer is still accounting for a large proportion of patients worldwide. And in India, of course, we know it's around 13.5%. Survival rate is poorer, earlier rate of onset, late onset of disease, a delayed initiation of treatment. So breast cancer in India is a significant problem. Now, when you look at the types of EBC, we have the luminal A, luminal B, HER2 enriched and triple negative, and the prognosis is worsening as you go towards the triple negative. For the current standard of treatment is, of course, giving chemotherapy either in the neoadjuvant or adjuvant, followed with locoregional therapy, and then endocrine therapy. So where does Abemaciclib fit in all of this? So Abemaciclib is now approved in the early breast cancer setting in these two areas. Either you should have more than 4 positive lymph nodes or 1 to 3 positive lymph nodes with at least one of these two. Tumor size more than 5, histological grade 3 at diagnosis. Now, please again note, Ki67 in India at least is not a part of the requirement for diagnosis for usage in India. So we are going with this particular indication, either more than 4 axillary nodes, or if you have 1 to 3 axillary nodes with one of the following: size more than 5 centimeter or grade 3. Again, I will leave it to Dr. Sendil to explain the trial itself and why these are included. What I will be talking about is trying to show you why these particular subsets have been included in this. Now, we know that in EBC, it is a bit of a wide group. It is not just a less than 2 centimeter T1 disease. Even T2 goes into EBC. Few lymph nodes is included in this EBC setup. You know, earlier we used to think anything more than 2 centimeter would be advanced. It's not locally advanced. It's still early. Now, the factors that affect the risk of recurrence: younger age, larger tumor size, higher grade, axillary nodal involvement, negative PR, and high Ki67. So with all these, when you start looking at different studies and the sites of recurrence, you see that luminal B and luminal A mostly go to bones. Pleura is an unusual site for both these luminal B and luminal A. Others, like the basal type, goes mostly for the lung and the liver. So these are the places where the relapse occurs. Now coming to the biomarker expression. So if you have obviously the ER/PR positive, that will be one of the lowest relapse rates. As you can see in this slide, the top 2 curves are the luminal A and the luminal B, and below is the other 2. So then when you study, people started studying this part. What is the recurrence pattern for these patients? Now, this was what was found is in those patients who are on endocrine therapy, the peak of the recurrence, there was an early recurrence peak, which occurred within 1 to 2 years. And that kind of correlated with the stage also. So even in stage 1, the peak is occurring in the first 1 year. So you see that big bump in the curve right there. That's the dark red line. That's early stage 1, then stage 2, stage 3. Everywhere, the peak is in the first 2 years. Then as per nodal recurrence, when you see, again, the lowest recurrence is for node negative. That's the green line there. Just above it, the blue line, that's 1 to 3 lymph nodes. More than 4 is, of course, at the top. So again, that tells you that when you have anything more than 1 node, 1 to 3 is worse than 0. 4 is much worse than these two settings. Again, when you start looking at the other parameters, histological grade, looking at the top graph, low grade, moderate grade, high grade. So as the grade increases, your risk of recurrence increases. The bottom one is looking for, again, the nodal status. Now, this is from the NEJM article on the EBC-TCG. So again, N0 is the bottom line, N1 goes above that, and the final one is N2, that is more than 4 nodes. So again, emphasizing that 1 to 3 nodes is at a higher risk for recurrence. Now, when they started looking at the endocrine therapy data, comparing the tamoxifen versus AI, again, AI had a slightly lower risk. And again, the peak of there was there in the first 2 years. And this peak and the early relapses have been attributed to the primary endocrine resistance. So primary endocrine resistance is what we need to identify. And once we identify that, the goal is to give treatment, trying to prevent and delay the recurrence in this group. So that's where the whole discussion comes around, that is there a group of patients where you try to intensify therapy and try to reduce the chance of recurrence? And that's essentially what the CDK4 has tried to do. So when you look at this graph, this is showing the Penelope, the Monarchy, the Palace, and the Natalie. All of them in stage 1, stage 2, and stage 3. The drugs are slightly used differently. The Palace was using in stage 2 and stage 3. The Penelope used in high risk after neoadjuvant. Now, Penelope used for 1 year, Palace used for 2 years, Monarchy uses for 2 years, and finally Natalie uses for 3 years. So Natalie is similar to Palace. Here it is stage 2 and stage 3. So Natalie has actually included node negative. It has included grade 2 also. Whereas when you look at the Penelope and the Monarch E, you included only high risk patients, wherein you tried to find a subgroup of patients who are going to be high risk. And again, looking at the prognostication, the tumor size, more than 2 centimeter, greater than 2, the ER expression, number of positive nodes, PR expression, the grade, and finally the Ki-67. The soft text trials have told us that these all are the prognostic factors for deciding the outcomes. So again, there was this paper which showed that the outcome in patients who had either 4 positive nodes or 1 to 3 positive nodes and grade 3 was almost the same. So again, back and back, we keep thinking, why this subgroup? Why were these patients included? This is the data behind it. This is the reasons why we use it. And logically also, when you have less number of nodes but higher grade, you do expect a higher chance of relapse. So there was a real world US study where they looked at recurrence risk using these combined things. And they used this particular criteria that has been used even for the Monarchy. That is more than 4 lymph nodes or 1 to 3 lymph nodes with 1 high risk feature. And there the disease recurrence risk is much higher for this high risk group. So the recurrence risk we typically say is very low for a ER/PR positive. But again, when you have these risk factors, the risk is actually higher. And again, in this high risk group, common sites of recurrence are the bone, liver, lung, and lymph nodes, distant metastasis, which tells you need a systemic therapy. So, changing your radiation, changing your surgery is not going to change this part. The distant recurrence has to be adjusted, and that will be done by your systemic therapy. Beyond this, there's also some molecular data coming in. We have been talking about this. So there is some data that FGFR1 would possibly be associated with the primary endocrine resistance. So overall, again, I would like to conclude my part of the talk by stressing upon this part. There is a group of patients wherein endocrine therapy resistance is going to be there. And that is a high-risk HR positive group. It will occur early, and possibly the best markers we have for identifying this group is the size, the nodal status, and the grade, all of which impact the recurrence risk, all of which have the prognostic for the relapse. Higher proliferation and lower ER will increase the risk. Luminal B, HER2 enriched and basal-like, of course, are high-risk features of the HR positive. So again, we have multiple genomic alterations that can look at this. There are certain now newer upcoming modalities. We know that if you cannot suppress the Ki67, that has a poor outcome. So in fact, that's where the current trials are going on. There is an ADAPT trial there, and there's one more trial wherein they're trying to give neoadjuvant immuno, trying to see what happens to the Ki67, and then randomizing to whether the patient should get a CDK inhibitor or not. So, we have plenty to discuss in our next 2-3 years. So I think even 2 years later, when we have a meeting in Varanasi, we'll continue to discuss something or the other on CDK4. So with that, I will hand over to Dr. Senthil, who will be discussing the role of Abemaciclib in particular and tell us where it should be and where it should not be used. So over to Dr. Senthil.
Thank you, Dr. Vamshi. Over to Dr. Senthil now.
You like to, yeah, that clock is reset. Thanks. Thank you, Vamshi, for laying the foundation for what I'm going to say in the next 11 minutes and 52 seconds. So what we will do is we will quickly run through some data regarding the role of Abemaciclib in these early breast cancer setting. Now, this is a slide that Vamshi showed more than a couple of times. So the point here is that even when you have 1 to 3 lymph nodes, if you're associated with other risk factors, your risk of recurrence is quite high. And you see that in the first 5 years, roughly 1 in 5 patients will get a recurrence then. If you've got 1 to 3 lymph nodes, and then if you add the other high risk features, which is tumor size and grade of the tumor, you will reach a recurrence that is very similar to what you get with 4 lymph nodes. So that is why in this study, this set of patients were included. If you come to the bottom of your slide, the assumed primary outcome in the control arm, okay, the control arm does not get Abemaciclib, is 82.5%. That means roughly we are targeting a set of patients who are likely to have an 18-20% risk of recurrence in the first 5 years. And that is the reason why that set of patients went into this study. So this is an early breast cancer study where if you have, so the study had 2 cohorts, okay, cohort 1 and cohort 2. Cohort 1 is a set which contained a group of patients who belong to this category. That means they had 4 lymph nodes or more. If you had 1 to 3 lymph nodes, your tumor had to be either more than 5 centimeters or you had to have a grade 3 tumor. Now, these patients were randomized after their standard adjuvant therapy, which could include chemotherapy, radiotherapy, whatever in the eyes of the investigator the patient needed. And then they were randomized to Abemaciclib, 150 milligrams twice daily, along with their endocrine therapy, which could be AI or tamoxifen, or endocrine therapy alone. So it's a simple, straightforward randomization asking a simple question. Is the invasive disease-free survival improved by the addition of Abemaciclib for 2 years? That's it. Now, I have boxed something specifically in that in the left corner of your slide, which tells you that patients could be randomized till up to 16 months from the start of their adjuvant endocrine therapy. Okay, 16 months from the start of your adjuvant endocrine therapy. Now, this is the patient disposition. As we said, this is a set of patients who got at least an 18-20% risk of recurrence in the first 5 years. Now, these are the various time points at which planned interim analysis were done. And the current analysis that I will show you in the next 5 minutes or so is the 4-year analysis. So this is the cutoff on 1st July 2022. Off study, that means almost all patients, 99.2% of all patients have finished their Abemaciclib and are off therapy at this point in time. Now we'll spend a minute or so on this slide because there are plenty of numbers and arrows that I have put up here. Now this is cohort 1, right? So this is the benefit of Abemaciclib in cohort 1. The light blue line at the top is Abemaciclib. the gray or the black line at the bottom is the standard arm. Now, the first thing is that the primary endpoint was achieved even in the first interim analysis. What you're seeing here is there is a slow improvement and an increase in the absolute difference. Now, in the first interim analysis, the difference was roughly about 3% between these two arms. That's gone up to roughly around 6.9% in the next readout. So there's nearly a doubling in 2 years, which is quite significant, I should say. There is a 35% risk reduction in getting the disease back. So patients who take Abemaciclib have got a lower risk of getting the disease back compared to if you did not take Abemaciclib. I think something very important for all of us to see is the control arm doing as expected? Now, I've pointed out that with the arrow there, you see that nearly at the end of 5 years, so that's an extrapolation to 54 months median, you see that about 78.6% haven't got a recurrence in the control arm. Exactly the 22% that Vamshi showed you more than a couple of times and the slide that I started with. So many times in these studies, the test arm looks better because the control arm is doing poorly. Here, the control arm is doing absolutely as expected. And in spite of that, you've got a test arm that is doing better than the control arm, and hence the trial is positive. Nothing much to talk about on this forest plot. The interaction p-values are not significant. So all comers benefited from the intervention in this trial, which is Abemaciclib. Vamshi again clearly showed to you that if you've got a higher risk population, you're likely to fail this stent. If you've got a T1 tumor and you're using endocrine therapy, if you looked at those studies where they used extended endocrine therapy, you will see that a lot of benefit is not because the drug actually prevents distant relapses. It's because it prevents a contralateral relapse. Okay, that's not the case here. As Vamshi said, distant relapse is what is more common, and that is what is being prevented by Abemaciclib. You see that 6.9%, it's 6.1% absolute difference here, not very different. 35% risk reduction, 35% risk reduction. So all the benefit that you get, or I would say almost all the benefit that you get because of the addition of Abemaciclib is because of the prevention of distant relapses. And remember that distant relapses are the one that's more likely to kill a lady with breast cancer. Now, we all know that results keep getting better for ER-positive breast cancer as time goes by. Is that what is happening in this study? Again, yes, you see that I've drawn an arrow downwards as to what happens to the split hazard ratios every year. You see that the hazard ratio is actually getting better. As events keep accumulating, hazard ratios are getting better, which means that it truly prevents relapses, and this number is only getting better over time. Now, a lot is said about Ki-67 because in certain geographies, the drug is approved only for patients who have a Ki-67% of 20% or more. But remember that this is only a prognostic marker. It is not a predictive marker. If you have a high Ki-67, you're likely to do poorly. But irrespective of the Ki-67, the drug seems to give you a benefit. And that's what is shown on these, on this Kaplan-Meier projection there, and on the table on the right side. I will not go into the details. It's going to consume a lot of time. Now, we also heard about many other trials that were done in a similar setting, the Penelope and the Pallas, both of which used palbociclib in the early ER-positive breast cancer setting, and a trial that's going on, called as the Natalie study, in which ribociclib is the test drug. Now, both Pallas and Penelope B were negative studies, while Monarch ended up winning the battle. Now, why do we think, do we really know the reason for why the palbociclib actually did not do well? The simple answer is we don't know. But whenever we don't know, we will try to propound a lot of hypotheses to say why palbociclib failed and Abemaciclib actually won the battle. Now, could it be because of the kind of patients that were included? Because Abemaciclib trial was smartly designed. They took a high-risk set of patients, while a significant proportion in at least the Pallas study were low risk. Now, they did a subset analysis of the high-risk patients in the Pallas, And even in that subset, there was no benefit of adding palbociclib. Did the duration matter? No. In Pallas, the duration was 2 years. You could say Penelope was negative because the duration was 1 year. Seeing all this, Natalie has extended the duration to 3 years. So it will be very interesting to watch whether duration really matters in terms of the benefit that you get. Now, could it be that abemaciclib is a better drug? Again, we simply don't know the answer. We at least think based on the continuous dosing, the differential inhibition of the CDK4/6 inhibitors, abemaciclib may be a better drug. But if you look at the metastatic setting, we did discuss about it this morning. The first line PFS for all of these CDK4/6 inhibitors are absolutely the same. So there may be some differences in the lab, but whether that difference actually translates into the clinic is something that we really don't know. One of the important reasons we think palbociclib might have failed is that based on the protocol, you had to discontinue the drug if you got into neutropenia, grade 2 or a grade 3 neutropenia. And all of this, all of us know that getting into neutropenia is just paper toxicity. So a lot of patients had to discontinue, about 42% had to discontinue. And the majority of these discontinuations were because of adverse events, and the majority of them were because of hematological side effects. So one of the reasons we think is that patients actually, nearly half of all patients did not actually get the drug through this 2-year duration, and that could have been one of the reasons. But as I started by saying, we just simply don't know the reason as to why one succeeded and the other actually failed. This is the updated adverse event profile. We clearly see that there is no new signal as far as the adverse events are concerned, but you will see that 18% of patients actually discontinue the drug, right? 18% will discontinue the drug, and at least a part of this is because of its adverse event profile, which you should clearly learn and make your patient aware of in order to use this. Again, this is mentioned earlier. The Indian approval for abemaciclib is node-positive early breast cancer at a high risk of recurrence. We're not talking about Ki-67 here. Now, the trial had a very specific set of patients who went in. What about certain other high-risk women that we see in practice? For example, somebody with node-negative disease. Remember that all patients who went into this study were node-positive. Now, suppose you have a T3 or a T4B with N0 ER positive, and the risk of recurrence is 38% as this lab report shows. Typically, this lady should be getting abemaciclib, but you can't give it because this patient was not part of the study. What about somebody with node positive who actually fits into the inclusion criteria of the study, but we did an oncotype DX and that is 18 risk score? Okay, typically a patient who would have gone into the Monarch E, but low risk, so typically does not deserve the drug, but can actually get into the study. What about HER2 positive patients who have a high risk of recurrence? The same patient, HER2 positive, higher risk of recurrence, did not get into the study. What about male breast cancer patients? Okay, should we do it? Should we not do it? I don't know. And then Olympia and Monarch E, how do you use both of these drugs? Can you use olaparib along with abemaciclib? The point I made earlier, you could start the drug till about 16 months from the time that they start adjuvant therapy. So if you're very particular to do this, complete 1 year of Olympia, and then you can get onto the Monarch. So there are so many ways of doing this. So to conclude, the benefit of abemaciclib seems to be getting better with time, seems to be like wine, right? The Ki-67 remains prognostic. It is not predictive. The benefit is irrespective of the Ki-67.